Okay, thank you everyone to join our how many the 10th journal club. So today and we have two fantastic speaker and they're talking about MPS 7 and the new ERT therapy. The first speaker is Dr. Jessica Bolen. She is the medical biochemical genetic fellowship at UT Healthcare. And so she will present she will be the first presenter. The second presenter is Dr. Ziats. She practiced in Cook Children's and also doing part-time medical biochemical genetic fellowship training. Welcome both of you. Thank you for sharing the learning.
Perfect. All right. So I'm going to start, and then we'll switch to Catherine, and then I'll end as well. Thank you everyone for being here this morning, especially when it's rare disease day slash time of year. So I know everyone is extra busy. We have a spot for questions and comments at the end, but if anything comes up that, especially if it's relevant to what we're discussing at that time, please feel free to interrupt or unmute. That might be the easiest way for us to be alerted that there's something to talk about. Uh, all right, I'm going to start with some of our learning objectives. And so these are going to include that by the end of the presentation, hopefully we'll be able to recognize some clinical features of mucopolysaccharidosis type 7, also known as SLY syndrome. We'll develop a baseline understanding of MPSs and then be familiar with a multicenter study describing enzyme replacement therapy for patients with MPS 7. All right, we're going to start with a patient case. So this was someone that came to us at UT. They were diagnosed with MPS 7, but this is going to be kind of their diagnostic odyssey. In the first trimester, the mother of the patient had normal imaging done, had a low risk NIP, and otherwise no concerns until the 22-week anatomy ultrasound, where the sonographer was able to find, and then the radiologist diagnosed fetal ascites, consistent with concerns. So they had some follow up at 23, 24 weeks. That imaging showed progression with scalp edema and then pleural effusions, as well as the diagnosis of fetal hydrops. At 26 weeks gestation, the family decided to proceed with amniocentesis, and molecular studies with CMA were negative. A whole genome was obtained at that time and was positive. And this is what the genome itself found. We had compound heterozygous VUSs and GUSB. The maternally inherited variant was intronic. It was reported in 2 individuals with MPS 7, and it met criteria for PP3, PM2 supporting, but was a VUS at classification at time of testing. And the second variant, which was paternally inherited, was a non-synonymous variant. It met criteria for PM2 supporting and then had a rebel score of 0.365. And again, because this was determined to be a VUS classification by the lab. Okay. Postnatally, because we were able to meet with the family prenatally, give the diagnosis, counsel them, and talk about the potential for ERT. The plan to go forward was we'd follow very closely prenatally and then postnatally start treatment. And we'll go into a little bit more about the pathways and everything and how that treatment was done. But on day of life 0, we met with the patient, met with the family right after birth, followed them, and they were able to draw activity for the enzyme through blood and then obtain urine gags. We were able to give the first dose of enzyme replacement therapy within the first day, within the first 24 hours of life. And it's dosed at 4 mg per kg. But just of note, because this is a very expensive and rare drug that wasn't going to be used again, it would expire before the next dose was due. We went ahead and gave the entire vial once it was open, and we had checked with the manufacturers to ensure that that was most efficacious. Our initial lab results, which were available about a week or 2 into life, were the enzyme activity at 0.23 nanomoles per hour per megaprotein, and that was reference range of greater than 3.50. So you can see that's severely depleted. Our GAGs were 315.5 milligrams per millimole, and that reference is less than 36.0. So consistent with our diagnosis. And after we did that first dose of ERT, we went ahead and drew another set of labs at day of life 8 and 30. The urine GAGs had come down to 158.6 and 101.6 at day of life 8 and 30, respectively. So not necessarily within our goal reference, but definitely improved from those initial lab results at birth. By day of life 14, we gave ERT at the second dose, again, 4 mg per kg. Because the patient had continued to grow and everything, you'll see we gave the entire vial when opened. So I believe this patient received 2 vials at the second dose because we were just over what was contained in the first vial. And we'll go into like how this is all important with the mucopolysaccharidoses. So, we'll try and be brief since this is not an unfamiliar condition. But the group of inherited metabolic diseases classified within the LSDs or lysosomal storage disorders. And just for a review, the organelle lysosomes are tasked with breaking down and recycling waste materials. The enzymes that are affected in mucopolysaccharidoses, which I'm going to try and remember to just say as MPSs from here on out, so for simplicity's sake, are known as glycosaminoglycans or GAGs. So that when I was speaking about GAGs earlier, that's what those are. And we have some pathways to show. But we have 1, 2, 3, 4, 5, 6, 7, 8 types of MPSs. And the one that we're most interested in is MPS 7 or SLY. It is, or the MPSs as a whole are very rare, but diagnosed in 1 in 25,000 live babies born in the U.S. Some states actually do tests for MPS 1 and 2 on their newborn screen. I believe it 2023, after one of the more recent RUSPs, we had somewhere between 35 to 40 states testing for MPS 1, and then I believe only 2 states testing for MPS 2. But that might have changed since then. Our biochemical pathways. So these are going to be one of the things we measure to or as biomarkers to diagnose clinically or per labs. We have heparin sulfate, dermatogen sulfate, and keratin sulfate. You can see beta glucuronidase, which is the enzyme affected in MPS 7, is involved in the HS and DS pathways. And when this enzyme doesn't work, we're going to have backup and elevations of HS and DS. And we'll go into that as well. But here for screening, one of the best ways and the more specific ways is going to be to look at the dermatan sulfate pathway and see that elevation. So usually we're doing screening with a urine spot test. We get a quantitative evaluation and qualitative to see where we're at. And I'm not sure why it says 6 now, actually looking at that, but that's okay. That's still where we're going to be looking for these. And then if these are all elevated and we're concerned, we can go ahead with molecular testing for the patients. So our MPS background, it's going to have a wide range of symptom severity. GAGs are going to be stored in multiple body systems. So we're going to have the skeletal structure, bones, connective tissues, organs all affected. Presentation is usually at birth or in childhood. Prevalence is estimated to 1 in 345 to 1 in 5 million worldwide, reported today in about 200 individuals. And we have a big list of the features, but we have some better slides to cover that information, including this one, which shows that we're going to suspect it most if patients are, affected with regression, macrocephaly, pain, or seizures. Ophthalmologically, we have corneal clouding. ENT can have recurrent otitis, macroglossia, enlarged tonsils and adenoids. This is all going with like the coarsening of features. Pulmonary, we see obstructive symptoms, obstructive sleep apnea, infections. Cardiovascular has thickening of valves and left ventricular hypertrophy. And then GI/GU has hepatosplenomegaly, umbilical or inguinal hernias, and then musculoskeletal has kyphosis, a gibbous deformity, the scoliosis, contractures, or joint stiffness. With the nervous system itself, we see damage to neurons or neurodegeneration, and then pain and movement problems later in life, especially after the patients are old enough to sort of communicate those symptoms. The again range is very severe. It can be average intellect in patients and to profound intellectual disabilities or developmental delays and behavior problems. There can be hydrocephalus in some patients with MPS. The accumulation of the gag zone in the eye, this is one of those hallmarks, can lead to an impaired vision by damage to the cornea and retina, increasing pressure in the eye as well with glaucoma. Standard therapies are going to be targeted towards the symptoms in each individual, and this is going to include like across all MPSs. They're going to be affected to a varied amount, and so we'll see some like personalized care plans with surgery if indicated, corneal transplant, which may or may not be successful in the long term, physical therapy and exercise, and then shunt placement or heart valve replacement. There have been enzyme therapies developed now since the early 2000s, so about 20 years, which makes sense as we're getting better technologies, better understandings of these diseases. In 2003, the FDA approved the first for MPS 1. And then 2005, 2006, 2014 all saw additional treatments targeted for other conditions. So at that time, MPS 1, 6, 2, and then 4A had enzyme replacement therapy available in the US. But when we get to MPS 7, SLY syndrome, this is going to be one of those ones that wasn't mentioned with the therapies available in 2014. As of 2024, there were about 200 to 300 patients living with MPS 7, which is a condition caused by reduced activity of the enzyme beta-glucuronidase, encoded by the GUSB gene. And again, this will affect how the body is able to degrade and process the GAGs, or dermatan sulfate, heparan sulfate, and then heparan sulfate. It results in accumulation in multiple tissues and organs, as we kind of discussed already with the MPSs as a whole. And testing can include blood enzyme activity of beta-glucuronidase and then urine GAGs. All right, and then here it was nice. It was a pathway of why this matters, why these GAGs are going to have the effects that they do. Roles of the GAGs include cell-to-cell communication. We can see accumulation with lack of plasma turnover, so even outside of the cell, and inflammation-related activation pathways. So this picture here I liked because it shows that the GAGs will act as damps or damage-associated molecular patterns, and then that they in turn activate inflammation throughout the body, and accumulation largely within the cells. There's lysosomes, autophagy, mitochondria, the ER, apoptosis, and then even our immune response outside of the cells. These are some features of MPS 7. From Montano et al. In 2016, we had a good sort of patient natural history, just being able to see the progression of the coarsening features and things. We usually expect it to present in the prenatal period or postnatal period. The mothers of these patients will have non-immune high drops on ultrasound in about a third of cases. That does not necessarily correlate, though, with long-term severity. So other features that we can see, which will all be patient-dependent, can include cognitive impairment, coarsening, cardiac disease, pulmonary disease, hepatosplenomegaly, joint or bone abnormality, short stature, and corneal clouding. Again, very consistent with what we know about the MPSs as a whole. Rate of progression is variable as well. So not only they'll present differently at birth, but throughout the rest of their lives, they'll sort of have their own unique path. There's not a clear correlation for geno-veno, and then we do even see intrafamilial variability. Most of these patients, unfortunately, do pass before the second or third decade of life. All right, and again, I'm not going to keep going through this too much, but this is just to show that MPS 7 is going to affect all of the body systems that we see with other MPSs, and kind of where our main focus is for sort of providing care to the patients would be. Treatment itself, again, it's a very recent development. but we do have enzyme replacement therapy with vestronidase alfa. It's recombinant human lysosomal beta glucuronidase, approved by the FDA in 2017. So about 9 years now. At the time of the patient's birth, it was only about 8 years. This is an exogenous enzyme that can be taken up by the cation-dependent mannose 6-phosphate receptor. And frequency of dosing is intravenous administration every 2 weeks via infusion. So as you can imagine, these patients largely undergo port placement once we're seeing that they are tolerating the enzyme and are not having anaphylaxis or other concerns. There is improvement in the multi-domain responder index and reduction in GAGs with administration. And so we're seeing good clinical and biochemical marker response, and overall is largely well tolerated. And that kind of goes back to, like in our case, the patient did have a response within the first couple of weeks, and then we continue to monitor those levels to see if she continues responding or has a good needs any adjustments to her doses. Treatment here, we can see how they were following response in Harmetz et al. In 2018. For the most part, they were showing that there was a response with meeting minimally important differences, or those MIDs. And so you can see like where the shoulder flexion or the joints are being affected, right? Visual acuity, and then fine motor and gross motor skills and fatigue. A lot of those very broad sort of systemic effects of MPS 7. Other treatments could be considered for hematopoietic stem cell transplantation, but this has mixed results and is very high risk, as we're all probably familiar with the complications that can come from HSCT. And basically, until ERT is widely available, this could be our only global defense against the lack of enzyme production in the body. MPS 7 surveillance includes growth, feeding, development every 6 to 12 months. We also will refer to ENT or POEM for that sleep apnea or obstruction, pulmonary dysfunction. They recommend neuro exam with consideration for spinal MRI, especially as they're growing and seeing if kyphosis develops. An ophthalmology exam really as soon as possible, and then for baseline, and then continuing. And then also echoes and EKGs for the valves, where we can see accumulation of the GAGs, and a dental exam. Every 2 years, these patients should undergo abdominal ultrasound, a nerve conduction study, and audiology exam. Again, looking for the features that we suspect most will impact patients in MPS 7. As clinically indicated, they can recommend PFTs, or pulmonary function tests, and sleep studies. And that's just to ensure patient safety, and that if they're needing other interventions, that those get provided. A lot of these patients will end up on CPAP, as we can kind of expect from most of our experiences with MPS patients. All right, and then I'm going to hand over to Catherine, who will let me know if I need to go ahead and fast forward for her. But if we have any questions thus far, I mean, this is a good point too for that.
Great, thank you, Dr. Bolen. So I'm going to talk about this article from May 2024, talking about disease characteristics, effectiveness, and safety of vestronidase alfa for the treatment of patients with MPS 7 in a disease monitoring program. Next slide. So the purpose of the article was to provide demographics, disposition, immunogenicity, hypersensitivity, adverse events, and efficacy outcomes of the disease monitoring program from 2018 to November of 2022, when they were analyzing the data for this paper. So the disease monitoring program is a prospective longitudinal study to characterize MPS 7 patients over time. They wanted to include treated and untreated patients. So treated meaning treated with ERT, not with stem cell transplant, and untreated, looking at changes in biomarkers, clinical assessments, outcome measures, and specifically in treated patients, how they did with ERT. Next slide. So again, the goal enrollment was 50 participants across multiple sites, 15 sites um, internationally, most in the United States. They targeted academic centers with experience with treating MPS 7. Every center also received training on assessment measures to decrease variability and to facilitate standardization. So data handling, so data was captured using validated electronic data capture system and was source verified for completion and accuracy based on the good clinical practice monitoring methods. They planned for interim analysis annually, and there was an advisory committee formed to provide guidance on design and contact data dissemination and publications. And that was started in 2018 when they started the program. So the eligibility, so they were inclusive, so no restrictions on treatment status. And again, they defined treatment as whether being on ERT or not. They required that individual have a diagnosis based on enzyme testing, which was also confirmed molecularly. Exclusion criteria were those that also were enrolled in another Ultragenic sponsored trial or any other biopharmaceutical clinical trial. The study visits, they plan for annual in-clinic visits at the study sites. For the first 2 years, if the individual was less than 5 years old, they asked for biannual visits, and just in the first year, if the individual was greater than 5 years old. So they conducted age-appropriate assessments. You can see the assessments on the table on the right-hand side. So demographics, family history, medical history, biochemical testing, laboratory testing, anthropometric measurements. They also looked at cognitive assessments, motor and function, patient and caregiver reported outcomes, pulmonary function, cardiac function, visual acuity, and hearing impairment. They also looked at efficacy and long-term safety data for those that were treated on ERT. There was no randomization. There's no formal statistical testing planned given the small sample size. Additionally, the assessments were amended slightly in 2001 to allow for remote enrollment visits, and that's because this was happening during COVID-19 epidemic. So again, the data was collected from January 2018 to November 22nd. There was 35 participants, 34 until November 22. One individual died from a recreational accident that was unrelated. Again, the majority were in the US. There were 7 untreated patients, 28 treated, 23 of them that started treatment prior to enrollment in the study, 5 during or after enrollment in the study. The mean duration of enrollment was 1.5 years. In the table on the right-hand side, you can see other demographic data. So the average age of enrollment was about 14 years old. And you can see the different ethnicities and races, and there was a pretty equal distribution of males and females. So going through their results that they collected. So there was 24 individuals with intellectual disability, most with profound or severe. Hydrops fatalis was noted in 2, but they suspected in up to 16 patients, and that was due to other symptoms that they noted at birth, such as anasarca, ascites, pericardial pleural effusions, abdominal distension. 4 individuals with preterm delivery. The most common medical conditions comorbid was rhinitis and hepatomegaly that were reported. Most common surgical conditions were myringotomy with tube placement, laminectomy, inguinal hernia repair, umbilical hernia repair was also common. On the table on the right side, they note the broad heterogeneity and pathogenic variants in the individuals that were in the cohort. You can see though that 7 were homozygous for this leucine 176 phenylalanine variant that has been implicated in an attenuated form of MPS 7. It's also the founder variant in Brazil. Next slide. So, regarding individuals that were on ERT, most were on the recommended dosing, which is 4 milligrams per kg, as Dr. Bolen told us about before. No serious hypersensitivity reactions were identified, and no association between anti-drug antibodies or neutralizing antibodies and serious hypersensitivity reactions could be determined. And no association between hypersensitivity reactions, anti-drug antibodies, neutralizing antibodies, and genotype or enzyme activity. Oh, sorry, on the last slide, if you go back, the table just looks at individuals that were started on ERT prior to enrollment. And it notes that the average age of those individuals when they started ERT was 8. And they had about 5 years of follow-up data in most of them. And I think that's all I wanted to show in that table. Okay. Regarding the anti-drug antibodies and the neutralizing antibodies, 92 samples were collected from 26 participants. They defined anti-drug antibody positive if there was a full 4-fold increase in the baseline titer, or a post-baseline of 1 in 40 when the baseline was negative. 4 patients were positive prior to enrollment, 7 positive during the enrollment or during the disease monitoring program enrollment timeline. For all of the ADA positives, they tested for neutralizing antibodies, and 2 that were positive also had neutralizing antibodies, but there was no loss of efficacy of the ERT that was reported, at least anecdotally. Other adverse events that they noted, there was 4 serious adverse events in 9 participants. 3 were thought to be related to the ERT. So there was hypotension in 2. One was classified as severe. The other is moderate. Both were intermittent and resolved. And then there was a low-grade fever. The remaining were thought to be unrelated to the ERT, included spinal stenosis, corneal clouding, hypoxic respiratory failure, clonus. They noted that no participants had cervical and spinal cord compression during the disease monitoring program period. So looking at efficacy of the ERT, they tracked the urine GAGs as a key efficacy marker. In the 23 patients treated prior to enrollment, they noted that there was a significant decrease in the dermatan sulfate, chondroitin sulfate, heparin sulfate from the initial baseline to when they were enrolled. And these changes, and that's what this graph is showing on the right-hand side, that the changes were maintained over at least 36 months, at least in a few individuals. If you go back, sorry. 5 patients that were treated during the disease monitoring program period, they didn't have enough data at the time of analysis to make any conclusions. And then unsurprisingly, in the 3 patients that were untreated at enrollment, they had elevated levels of the urine GAGs. Next slide. So this graph looks at percent change from initial baseline in height by visit for the treated patients. Interestingly, for the treated patients, the initial baseline and post DNP enrollment individuals had Z-score values that were similar. And so there was no trends that they can make regarding height. And the Z-scores for height and length at enrollment for those treated prior and those treated after were not that dissimilar. So for the 6-minute walk test, they had data for 21 patients, and those treated prior to enrollment. They had data over 48 months, and they didn't show any significant clinical change. In pulmonary function, there was also limited data. They felt that the data was limited by the individual's ability to follow instructions and also some of the learning concerns that a majority of the individuals enrolled had. They did have 8 patients with post-EMP enrollment visit data that showed some slight improvement in the FEV1 and FVC, but all within the normal ranges, and then generally improved trends in those treated with ERT and their cough peak flow. Regarding cardiac function, they have data about 28 individuals, and a degree had aortic valve incompetence, mitral valve incompetence, and tricuspid valve incompetence. No follow-up data was recorded for any of that. They did have left ventricular mass index available in enrollment for 12 patients, and those treated prior to enrollment, 5 patients treated after, and 2 untreated. They noted some decreases in LVMI reported in patients treated with ERT, but again, not enough information at this point to draw any clear conclusions. So their conclusions were that this disease monitoring program provides a comprehensive standardized data set. They noted no new safety concerns with ERT, overall a good risk benefit profile of ERT, decreases in urine GAGs with the start of treatment, and that they were maintained while being treated. They did include patient and caregiver outcome assessments, but there was no data or no conclusions that they can draw at the time of publication, given the limited data that they had available. Some of the limitations were that there was a thought that perhaps only milder cases were included. The majority of individuals were milder in phenotypic severity. Again, limited patient numbers and data, and then unanticipated that their data collection period was during the COVID-19 epidemic, and so several visits could not be performed, and at least one individual missed enzyme replacement therapy due to illness. So their hope is that with this study, they'll be able to include patient and caregiver outcome assessments, and they'll have some longer term data where they could better understand the natural history of MPS 7 and importantly as well, the efficacy of ERT. So I'll turn it back to Jessica.
All right, thank you, Catherine. Appreciate that. Just to revisit our case, so our patient follow-up has been kind of difficult. She was in the NICU until about 1 month of age, and then seen in clinic at 2 months old. She does follow with multiple specialists, including cardiology, orthopedics, ophthalmology, audiology, neurology, us, and then pediatric surgery for that port placement. Not very surprising, since those are sort of the systems we'd want to get a baseline understanding of and then follow throughout the course of her disease. But she was scheduled to receive ERT infusions every 2 weeks, again at 4 mg per kg dosing, with just using the completion of the vial if appropriate. Our biggest barrier to care has included insurance, kind of pushing back on the first 2 outpatient ERT infusions. And then also just transportation, as this family lives an hour away from our center, and there's understandable difficulty in getting here, but otherwise they've been very compliant, very good about communicating with us. Her current problem list includes, mostly things associated with MPS 7, so not that surprising. She did have a spontaneous PDA closure after birth, and then was diagnosed on that initial echo with a PFO with left to right shunting. So continues to follow with cardiology for that. She did fail her first hearing screen. It was still to be repeated. When I last checked in her chart, her head ultrasound at birth had shown mild dilation of the left lateral and third ventricles, but no hemorrhage. She had equinovarus bilaterally, so was following with ortho for potential casting. And then her bone survey after birth showed slight symmetrical elevation of bilateral superior lateral corners of the orbits, without obvious cranial sinus stenosis, otherwise a negative study. And so that was kind of interesting to us that it was just above the eyes on her skull, and then not really anything noted elsewhere. Her development, unfortunately, she was still showing some delays with the inability to roll from tummy to back at, I believe, about 9 months of age, and then not supporting herself while sitting. But in like better news, she was having tolerating term formula PO feeds. They worked very hard in the NICU to get her not needing an NG tube. And then they also noted a normal ocular exam and hip ultrasound after birth. But we're continuing to follow this patient and see her more often in the infusion center than in clinic. But, the parents are, again, good at communicating with any questions or needs that they end up having. All right. And we wanted to see if there were comments or questions at this point. I don't see any in the chat.
Yeah, I didn't see anything in the chat. Oh, Peter.
Hey, good job presenting,
Oh,
you guys. That was really good. So I have a quick question for Catherine about the paper, and I'm curious. First, well, two questions. First, did they say why their data was so low in terms of number of participants versus the data points that they got? And then second, with the limited data, were they able to compare early starting versus later starting, so younger versus older who are on ERT?
So the answer to your question two is no. And question one, yeah, I thought that was kind of strange as well, because even though there was 34 that were included, for a lot of the parameters that they looked at, they didn't have 34 data points. And they didn't comment on that. I suspect that a lot of it had to do, honestly, with some of the mixed visits regarding after COVID-19, they had to transition some from in person to virtual. And I suspect that some of, for example, like, measuring, their echo and cardiac function and PFTs and things like that might have been because of the virtual visits. But no, they didn't say specifically.
Thank you. Yeah, I mean, with the number of enrollees, 34 or 35, to have maybe 13 data points or 13 participants with multiple data points for each, that's a huge drop off. But thank you very much. Great, again, both of you guys, great presentations.
Very impressive, and you guys can get the patient's ERT started on the day one. That's a huge effort to make.
that was definitely on behalf of our genetic counselor who was on the case, and then also with the manufacturer of the drug. We were able to get all of that organized. It was exciting. It was exciting, but also stressful. But as we expect.
I guess in with those the new like efforts and for prenatal treatment, and hopefully in the future this can be even initiated early and for this prenatal onset cases.
Yeah, the goal had been actually, there was a study ongoing that I didn't mention here, but for prenatal administration of the ERT, unfortunately the family was not able to travel it was across the country. And so we luckily with the genome results, we're able to at least know the diagnosis and get that started as soon as we could.
Mm-hmm. There is a question, Dr. Kanogo.
Yeah, hi. Would you guys be like having a long-term follow-up? Because that would really generate a lot of interesting data. So please, if you haven't thought of it, do so and keep us posted on it. Thank you.
Yeah, absolutely. No, that's a great point. And she's less than a year old right now. But certainly as we see more and more of what she's able to do, we'll be doing that.
Can I ask one more thing? Sorry, we have a similar kiddo with MPS 6, and the parents have been really hesitant to start ERT. Were these parents at all skeptical, hesitant, pushing back? Or was there any negativity surrounding starting it?
No, for sure. I'm going to say luckily, but like fortunately, we had the luxury of having the fetal center here with our institutions that we were able to counsel on a lot more extensively, maybe than some people are able to do. And so there was a lot of that meeting them where they were at psychosocially months before delivery, and kind of talking about how these would go. I would say like the most stressful time was probably that second dose, when we would see or expect to see any anaphylaxis if it were to show. And I'd mentioned it that we did that inpatient and we continued to do that until she was ready for discharge, which gave us all a lot of peace of mind for what we could provide with the family. But no, I wouldn't say that they were extensively like nervous, any more so than anyone who is about to become a first time parent.
But I think it's different though, right?
Mm-hmm.
Because I have another patient with this condition who has every complication of MPS 7. And so I think it's a lot easier to conceptualize like why you would start treatment as opposed to a newborn baby. And I think that's maybe the point that you're getting at, that, looks like an otherwise normal baby. And, these were variants of uncertain significance. I think I remember, is that correct?
Yeah.
And so, I think, there's, I think there's going to be some hesitation and, on the part of the parents, which is natural.
Yeah, pre-symptomatic is a much more difficult sell than severely symptomatic and even somewhat symptomatic. But yeah, thank you very much. That's helpful.
Yeah. So, Jessica, I have a question. What's the general practice prenatal identified non-immune like high jobs? Do they
Um,
do exome, like
it,
amniocentesis and exome?
I would say it most like for with us, our prenatal GCs and MFM providers work a lot closer with the family. This time we were able to come in because it was going to be a postnatal treatment.
Mm.
But it depends on their comfort level with amniocentesis. If we're able to like go ahead and get broader testing with a genome, or if we're just going to go off of NIPS, things like that.
Mm.
But that's a good question. Yeah, I think it's just very
Yeah.
case by case.
Yeah. So,
Yeah.
citing some of this like treatable lysosomal condition could be like impact the immediate management after born, right? So,
Certainly.
yeah.
Yeah.
And so I saw New England Journal published that paper and just for non-immune high jobs and a lot of patients and identify metabolic and also the resopsy. And so that's
hmm
definitely and I just don't know and in practice and where we are.
No, sure, certainly. And I think yeah, as more of these ERTs get approved or are becoming available,
Mm,
and the earlier we're able to start, the better type of thinking.
hmm.
That's definitely going to be a good proponent for prenatal testing and getting that
Yeah.
kind of information available to families and providers.
Maybe you should write it up and just allocate for this.
Yeah, ideally, yes, yeah. Definitely. I think we were kind of waiting to see how the patient did long term,
Hmm.
or not long term, but longer term,
Yeah.
before pursuing that route.
Hmm.
But no, thank you for the advice.
Any other questions? Okay. We finished early. Thank you for sharing the cases and the articles. I hope everyone has a great weekend and enjoy ACMG next week. All right.
Thank you.
Thank you, Chris.